Hello there, this is Dr. Brian Buchanan. We'll be talking about detection of hemothoraces and pleural effusions as a component of the EFAST exam. For our learning outcomes, we will develop a consistent approach to performing and interpreting focused thoracic ultrasound. We'll touch on differentiating from atelectasis and consolidation, and integrate those clinical findings with our assessment. Although we'll be focusing on hemothorax and trauma, it's important to acknowledge that ultrasound is good at detecting all kinds of effusions, whether from heart failure, atelectasis, pneumonia, hepatic hydrothorax, or cancer. So these are all important part of the differential and indeed are an important part of the patient's clinical history. So how do we perform this procedure? Well, we can first of all use a phased array probe, which has a low footprint and can get in between rib interspaces. We can also make use of a convex probe, which casts over multiple interspaces. Notably, the marker on the probe is on a cephalad position. This image is acquired in the coronal plane. Again, we can see the probe marker is screen left, and that corresponds to the probe marker, which is also towards the head. We can see the difference in acquisition here from a phased array probe versus a convex probe. Again, the phased array probe can sneak in between interspaces, and the convex probe casts over multiple. Our goal for assessing the thoracic space should be aiming for a target depth between 16 to 20 centimeters. Again, keep in mind the coronal plane divides the dorsal and ventral portions of the body. On most machines, the abdominal preset is the most effective mode. And this again will keep the probe marker screen left. Knowing your landmarks for assessment of hemothorax is critically important. Here's a cartoon illustration of the right side of the thoracic cage. We can see the liver, the most inferior portion, the diaphragm, the pleural space, which here is an anechoic space. In a healthy patient, this space is non-existent. The lung and the spine. If there is no pleural effusion, we will generally not see the spine as air causes intense scatter. Again, this is a coronal section of the body. Here's a normal reference picture from a normal right costal image collected at the mid-axillary line. We can see the diaphragm, the abdominal viscera, which is the liver here. This area represents the pleural space. And we don't see an anechoic space. What we do in fact see is perhaps some suggestion of sliding in A-lines, as this is healthy lung, which is inflating and causing a curtain-like sign over the diaphragm. It is not uncommon to see a small area of what's called a mirror image artifact, which duplicates the texture of the liver above the diaphragm. This is an artifact beyond the diaphragm and is not the true pleural space, as there is no pleural effusion here. The left side anatomy is very similar. And again, I would encourage you to aim for the mid-axillary line and start caudally and head more cephalad, as you want to aim to go through the abdominal viscera as an acoustic window to see the pleural space. Pleural effusions and consolidations look radiographically very similar. In fact, in this particular radiograph, a patient who is post-admission day 2 from a trauma is shown to have enlarging moderate right-sized pleural effusion. When you apply the ultrasound probe at the mid-axillary line, we see something very different. Again, we see the diaphragm, we see the liver. This is the pleural space, and we can see the spine as well. Now, this texture is clearly not anechoic. In fact, what we're seeing here is an area of dense consolidation, or tissue-like, or hepatization. As the lung, in fact, is so consolidated, it looks like the liver. Again, we are seeing that spine because we now have an acoustic window to the spine. This is an image collected from a patient, the left mid-axillary line. We can see a large anechoic space with the clear margins of the diaphragm. We see the spine, again, with an acoustic window with fluid. We see the base of the lung and the chest wall. We see that our marker is screen left. Just to quickly explain the spine sign. So on image right, we see the clear spine in the far field. On the left, we are not able to see the spine. And the reason why is because above the diaphragm, the air is causing intense scatter, not allowing us to visualize through the lung to see the spine. Whereas on the right, we have a clear acoustic window filled with fluid that allows transmission of sound waves. Here's an example of a false positive pleural effusion. Now, a novice sonographer might look at this and declare that perhaps this is lung, as it is surrounded by anechoic space. But if you look closely, you might understand that, first of all, this is the diaphragm. And below the diaphragm is the anechoic space. Therefore, these organs here are likely the spleen and the kidney. and the pleural space is in fact above the diaphragm. Therefore, it is critically important that you understand the margins of a pleural effusion. Approaching thoracic ultrasound requires a systematic assessment. If there's any ambiguity on whether or not there is a pleural effusion, and the patient can tolerate waiting for further investigations, a CT is definitively warranted. The appearance of a fresh hemothorax is anechoic. Depending on time of transport, if the patient is waiting a few hours, it may become more hypoechoic as it gradually clots, or it can become kind of a mixed texture between hypoechoic and anechoic. You are less likely to see isoechoic or hypoechoic effusions. So let's review those steps. Know your anatomy. Again, I cannot stress this enough. Differentiating effusions from consolidation, making sure that anechoic space is indeed above the diaphragm, and realizing this appearance can change from anechoic to hypoechoic to more heterogeneous. Finally, you should know that thoracic ultrasound performs more like CT than X-ray. As we can see here, it demonstrates 100% sensitivity on 100% specificity. But this requires practice and due diligence, as we've discussed. I'd like to thank you for listening. Bye for now.